starts while that screen warms up. So my name's Rachel French, so thank you very much for this opportunity to come and present to you today. I'm going to discuss CFS, ME, IBS and fibromyalgia. Is it a chance association or is there indeed a common pathway? I'm a colorectal surgical registrar up in the northeast, and this is some of the work I've been doing whilst out of programme doing clinical research fellowship. Couple of disclosures. One, I'm a surgeon, not a medic, and two, I deal with things I can see physically with my eye. I'm not very good with bio small things I can't see, so if you keep questions simple, I might be able to answer them. If they're too difficult, I might struggle, but I'll give it a go. So what I'm going to do, I'm going to have a chat and a discussion quickly around the conditions themselves. Obviously you know a lot about CFS, ME, but also about IBS and fibromyalgia. Look at what we know anecdotally, what the suggestion is, and also look at what the evidence is there so far, and is the association real? If it is, what's the cause? Is there a common cause? And some ongoing research with some preliminary findings that I've been doing as part of my MD. So CFS, I'm not going to dwell on this for too long because you all know it. It's very vague, and there's no diagnostic test as such. Prevalence, nice quota at 0.2 to 0.4%, but as we've already discussed earlier today, do we really know how many people are suffering from it, as it's often underdiagnosed? And management options, unfortunately, are limited, and often are things like CBT, graded exercise, and sleep management. Irritable bowel syndrome is a chronic condition affecting the GI tract, often characterised by pain, which is associated with a change in bowel appearance or frequency, but there's no structural cause that's causing it within the bowel itself, and there's no organic cause. It's diagnosed with the Rome 4 criteria, which you can see there, but essentially it's pain associated with bowel function. It's much higher prevalence than CFS and ME, and again is likely to be underestimated, but the prevalence reported is around about 11%. Often patients have multiple visits, again similarly to the GP in the hospital. And likewise, IBS has been proven to have similar costs to other long-term conditions such as asthma, migraine, high blood pressure and heart failure. It's subtyped depending on the appearance of the stool. Again, sorry, I'm a surgeon, but again, based on what the stool looks like, whether it's constipation predominant, diarrhea predominant or a mixture thereof, based on the Bristol stool chart. So fibromyalgia is also another chronic condition that causes widespread pain and tenderness throughout the body. It's commonly quoted to have a prevalence somewhere between 4%, so 1 in 25 people approximately. And again, it's a clinical diagnosis supported alongside the widespread pain index and symptom severity scale. The widespread pain index essentially looks at all of your muscles throughout your body and tender points. You tick whether or not you've got pain there, you add up and you get a score, and you combine that with the somatic symptoms as well. So anecdotally, we know that what we see in our clinic in Durham and elsewhere in Newcastle and in the northeast, that often our patients that come to our bowel clinic do have symptoms suggestive of fibromyalgia or CFS and ME, or indeed have a diagnosis of those. And we thought there must be a common cause, there must be something underlying this, because the converse was also the case in other clinics. So patients in the CFS clinic, for example, would have bowel symptoms. But we didn't know exactly what that relationship was. So first question really was, is it a real association, or are we just seeing a bizarre perception that we're seeing in clinic and getting skewed results? So what I did was a literature search to see what the evidence is currently. I did a search and got down to essentially 38 articles in the end, which I've reviewed and looked at the reported prevalence. What I found is that, so it's really quite small, but there's a huge amount of papers, particularly looking at fibromyalgia. So the condition down the left is the index condition, and the conditions across the top is the comorbidity, so what they've also got. So for example, an IBS patient with fibromyalgia as a comorbidity, or a fibromyalgia patient with IBS as a comorbidity. There's a lot of research in fibromyalgia and IBS, none that I could find looking at the cross-prevalence between CFS in a population of IBS patients. What you also see is that there's a big spread in the reported prevalence, and often the studies were small numbers and not many large, robust epidemiological studies. Looking at some of the results, again this chart shows the scale on the side and looking at crude numbers of patients involved. So for example, patients with chronic fatigue syndrome, looking at their prevalence of fibromyalgia as a comorbidity. You can see that in the study there was over 1,800 participants, of which over 1,000 fulfilled criteria for fibromyalgia. However, when you looked at things like chronic fatigue syndrome with the association of Ehlers-Danlos, very small population that was studied, obviously then it's very difficult to draw sound conclusions from because you're dealing with a much smaller pool of patients. Oh, it's all right, sorry, wrong button. If we look at that proportionally, and exclude for the fact that they're large studies and small numbers, and look just at the percentages, we can see that CFS as an index condition, so population of patients with chronic fatigue syndrome, looking at their comorbidities, be it IBS, fibromyalgia or Ehlers-Danlos, seem to have a much higher cross-prevalence of these conditions when compared to other cohorts. Similarly, fibromyalgia's high, but not as high when you've got CFS. But patients with IBS as their index condition had a much lower reported prevalence, for example, of fibromyalgia, comparative to the chronic fatigue syndrome patients, which had a much higher reported comorbidity. And similarly, Ehlers-Danlos was much lower reported prevalence. Oh, sorry, it's not moving on, there we go. So community studies, the difficulty we had here is we were looking at really very, very small numbers of population that had been studied, 30 to 35 participants. It's really very difficult to draw any conclusions when you're dealing with such small numbers. If you think there's only 5 or 6 patients, for example, with CFS that were reported with IBS. So it's very, very difficult, and as a result we excluded those papers. So the question is this just we're just seeing it, or is a definite difference? And is there a difference in the populations when you compare them to healthy controls? So if, for example, you take the first 2 bars, they represent controlled studies where patients had fibromyalgia as the index condition and IBS as a comorbidity. And the first bar is the diseased population. The next bar along is the healthy controls. And if you look at the blue columns for percentage prevalence, there's a 55% prevalence of IBS in the fibromyalgia population, whereas in the healthy controls it's approximately 10%. So clearly there is a difference amongst this, and it's not just by pure chance that we're calculating that. There is obviously a difference, and you can see that with each of the bars there is a big difference. So in answer, yes, there is a difference, and clearly there's something going on here. And if there is a difference, what's the cause of it? What's the causation? Is it, dare I say it, psychosocial, psychological? Are we getting an element of referral bias? Or is there indeed a shared common pathophysiology? There's a lot of evidence and there's a lot of papers out there looking at psychosocial and psychological elements to all conditions. I've predominantly looked at IBS because I deal with bowels. And what we see is that patients' perception of their own health when they have IBS is much lower than a non-IBS population. Psychological morbidity is associated with increasing number of comorbid MUS conditions, medically unexplained conditions, and a lower ability to cope with them. Similarly, if you've got more increasing number of extraintestinal symptoms, for example, fibromyalgia and chronic fatigue or pelvic pain, you do have worsening of your bowel symptoms. So the more medically unexplained symptoms you have, the worse the impact on that patient, particularly in quality of life, absence from work. We've already discussed the sort of health economics impact of that. But it's a bit of a chicken and egg situation. What came first? Are patients having psychological ill health because they've got chronic fatigue and their ability to do what they want to do is hindered? Or is it the other way around? Is that psychological ill health causing the fatigue? It's difficult to pull that out because obviously it's very much chicken and egg. What we do know though is that psychosocial morbidity is a factor in manifestation of medically unexplained symptoms and may be a partial factor in causation. But we can't say definitely that that's the only case, and obviously there must be something else going on really. So is it a case of referral bias? I work in a tertiary referral centre in the North East. We get referrals from across the country to come and see the professor I work for. We obviously see very severe refractory patients to normal medical management, and therefore their symptom burden would be worse. So if you look at this group of population of the patients, and I've looked particularly at functional bowel disorder, but you can apply this to any condition really. Within the normal population and community, you'll have a lower prevalence of functional bowel conditions because you're dealing with a larger number of patients. The number of patients that then present to primary care with their functional bowel problems will be much smaller. And likewise, by the time they've reached secondary or indeed tertiary care, the numbers are much smaller, and therefore you may indeed have a higher prevalence reported because you're dealing with much more complicated patients. Similarly, if you compare irritable bowel syndrome with IBD, so the green triangle represents the population, the yellow circles represent medically unexplained symptoms of patients with medically unexplained syndromes. Within the population, prevalence may be the same. The blue line represents the threshold for reaching a diagnosis for either condition. And with IBD, we may diagnose more patients with IBD because they've got symptoms that make them present to healthcare, be it bleeding, change in bowel habit. However, if the population with medically unexplained symptoms have a high potential for presenting to healthcare, then you'll see a smaller number of people, but a higher proportion of which would have medically unexplained symptoms. So that's a possibility of referral bias. However, there's other options, and we know that in literature, there's evidence for all of these as causation factors within the conditions preceding infective triggers. For example, we know that if you've had an infection or a DNV bug, proportion of patients will then go on to develop irritable bowel syndrome, of which most will recover, but some will continue and stay in the population of IBS. Likewise, there's evidence that genetics play a factor, immune dysfunction, the gut microbiome is a hot topic, and autonomic dysfunction. They're all possibilities. So how do we move forward towards finding an answer? So my research project was the overlap project, and that's exploring the association and overlap between disorders of medically unexplained and organic nature. What it was, or what it is two studies within it: a prevalence study looking at the medically unexplained symptoms, and a surgical study. Because I'm a surgeon, I like to look at what the impact is on pelvic floor. The aims of the prevalence study is to characterise the cross-prevalence of medically unexplained symptoms, looking at is there a temporal relationship, so does one lead on to the other, and also assess the impact that multiply affected patients have on their quality of life. We're also consenting patients for future contact to participate in ongoing studies, so this is the first step of a large research project. The aims of the surgical study is essentially to assess, does the presence of medically unexplained symptoms have an effect on the outcome of pelvic floor surgery? LVMR essentially stands for laparoscopic, so keyhole, ventral, front, mesh rectopexy, so hitching the rectum up back to where it should be, predominantly in ladies following childbirth or just joint hypermobility and generalised saggy perineums down below. Okay. We included anyone over the age of 18 who was willing and able to be involved and gave consent to be involved, seen in any of the tertiary referral clinics within the 3 trusts, or organic controls which we selected with inflammatory bowel disease. They needed to understand written and spoken English because the way we conducted the study was with questionnaires and screening tools that we've already discussed. So we asked the screening questionnaires, including the Rome criteria, looking at orthostatic symptoms, looking at widespread pain. Also, for the surgical patients, we looked at their outcome of surgery. Were they happy? Was it a success? Did they have complications, for example? And another key question of, would they have it done again if required? We also collected demographic data using the postcode. So recruitment to the prevalence study, I will say this is still ongoing. IBS is the clinic I work in, so understandably we've got a bigger pool of patients we've recruited much quicker. But the other studies are also ongoing, and the recruitment is ongoing, but we aim to recruit a total of 600 patients from the 4 clinics.